a really wonderful session today that we're going to have, a very interesting topic, pediatric transplantation in a resource limited setting. And I think we do have three very eminent pediatric nephrologists from Africa here today. So I think I will leave the whole session to them. I call upon Dr. Francis to do the introductions, and then we will move on to Dr. Bashir. Thank you very much, Dr. Bashir and Dr. Francis. Thank you, Dr. Bima, for coming on as well. So over to you, Dr. Francis.
Thank you.
Thank you.
Thank you, Dr. Lloyd, for your kind words. So may I take this opportunity to welcome everybody that has taken time to join us this evening. Today we have Dr. Bashir Admani. He's an eminent pediatric nephrologist from Kenya. He's a friend and a colleague. We trained in the same place under the same mentor and at Red Cross. So he's currently working as a he was trained in MBChB and MMed Pediatrics at University of Nairobi, and then he did his fellowship in pediatric nephrology at Red Cross Children's Hospital. And he's currently working as a consultant pediatrician in Nairobi Hospital, and he's also consulting at St. Gertrude's Children's Hospital. And he's also a lecturer at Aga Khan University, I believe. So lecturer at the University of Nairobi. So we are looking forward to hearing from him. The challenges that we do get in pediatric transplantation. We all know that pediatric transplantation is challenging even in developed countries. But then I guess there's an extra layer of difficulties when it comes to the resource limited settings. So I believe Dr. Bashir will take us through and at least share with us the challenges that one has to navigate to make it successful for pediatric transplantation. Welcome, Dr. Bashir.
Thank you, Francis, for that introduction. Yeah, good evening, everybody. Like Francis said, I'm Bashir from Kenya, and yeah, my area of specialty is pediatric nephrology. I'm an IPNA counselor for representing Africa and part of the African Pediatric Nephrology Association. So I'm going to try to present. Basically, yeah, so the topic today is pediatric renal transplant in resource limited settings. These are the institutions I'm associated with. So we all know that there have been many advances in conservative renal replacement therapy, things like hemodialysis and peritoneal dialysis. But renal transplantation is the best treatment for children with end-stage renal disease. This has been shown in many studies, but the study from Australia and New Zealand, in which the risk of death was more than 4 times higher with dialysis than with renal transplant, which was published in the East African, in the New England Journal of Medicine in 2004, showed clear advantage of transplant vis-a-vis dialysis. So when you look at Africa, pediatric renal transplantation in Africa has been largely confined to North and South Africa. Sudan has been involved in a lot of pediatric renal transplant in the last few years. When we look at our country, Kenya, we had very few transplants taken place though our transplant program is actually one of the oldest in Africa, it's over 20 years old. And we never used to do pediatric transplant until very recently. So it's still a developing process. If you look at the global situation, when you look at global transplant activities, this is the pre-COVID situation. As you can see, Africa, either we don't have data or it is not appropriate. So South Africa, Sudan, Egypt, there's no data from Egypt, but Egypt, North African countries tend to do a lot more transplants than most of the other countries. When you compare it to North America, Australia, Europe, you see the drastic differences. And this is for all transplants, not even pediatric. And if you look at pediatric transplants, it's even worse. What about in my country, Kenya? So we have, this is the map of Kenya. For those who don't know, we have 2 centers, Eldoret and Nairobi, where most of our pediatric, in fact, all of our pediatric transplants take place. They don't take place outside these two centers. So if you look at our local experience, Eldoret Moi Teaching and Referral Center, this is run by my colleague and friend, Philip Cheptinga. For the last 5 years, they've done 16 transplants. The youngest been 5 years, and 1 year graft survival rates of 100%. So they're doing quite well. Kenyatta National Hospital, the other hospital, the last 5 years, we have had 12 transplants, youngest being 9 years, and 1 year survival rates of 92%. And when we talk about this, last 5 years, obviously the last 2 years have been difficult because of COVID. We did 1 transplant last year in my center at the start of COVID, and patient did well. But after that, the transplant program had generally been brought to a halt. So transplant for us is a big event. As you can see, this is a picture of one of our patients who was transplanted. You see three pediatric nephrologists in one city coming to see this particular patient. So we all work as a team whenever we have a transplant happening. So the objective of this talk, I thought I'm going to use a case presentation to discuss principles of pediatric renal transplant and challenges we have been faced that can be faced when you're doing transplants in resource limited settings. So I present this child, FO, is a 12-year-old boy. The first child I transplanted when I came back from my training, and we hadn't transplanted a child since the first transplant in the country. That was more than 20 years prior to this. He was referred from our lakeside city, Kisumu, with a swelling of body on and off for the previous 3 years. When he came in acute state, respiratory distress, semi-comatose, was anuric. On examination, was found to be grossly edematous. 150, was pale, had features of pulmonary edema as well. When you looked at his kidney function, urea BUN of 50, creatinine of 2,150, so was in end stage, potassium of 6, HbO was 7 grams per deciliter, ultrasound had shown small contracted kidneys, 5 centimeters, no features of obstructive uropathy. We started him on hemodialysis with a preliminary diagnosis of acute on chronic kidney disease, improved on hemodialysis, general condition, but remained anuric for more than 8 weeks. Now the problem was this boy was an orphan. Both his parents had died. He was looked after by a blind grandmother in the lakeside town in our country. He had no siblings. He was being taken care of by his neighbor. And in our country, legislation at that time did not allow for cadaveric transplants. So the question for me was to dialyze indefinitely or to transplant. So the neighbor, who was not related to this child, wanted to help this boy and was willing to donate her kidney. A lot of counseling took place. We had the blood groups matched, HLA typing was done, and we had a 1 in 6 match. So 5 in 6 mismatch, but we didn't have a choice. When you look at the studies which have been shown, which have been done, when you look at superior HLA matching between recipient and donor, whether it's deceased or in living related, is associated with improved outcomes. For example, the 5-year survival rates, if 2 HLA mismatched kidneys, was 69 and 65% respectively. So when you look at 0 vis-a-vis 2, so the worse, the more the mismatch, the worse your outcomes. Now, when we look at actual donors from deceased persons, this is another, when you look at this World Health Organization picture, Africa, the only places that do deceased transplants, probably South Africa. When you look at Kenya, where my country, we don't do any deceased transplants, neither does Sudan or Ethiopia. Now we are into the legislation where we are trying to get the legislation going in our country, where we should be able to do cadaveric transplants. What this tells you is that our pool of kidneys then becomes less, because all we rely on is living related donors. So if you don't have a really living related donor, your chances of getting a kidney is poor. Again, there are issues with donation, education of people to donate the kidney. A lot of counseling goes into this, and many a time we still have people who refuse to donate their kidneys. So this is something that can change in terms of kidney harvest. If we can get legislation going in Africa where we can do cadaveric transplants, then it's going to make a big difference in terms of kidney availability for transplantation. All right. So we got the kidney, did the typing, this is a pre-transplant workup, as I'm sure you guys know, donor, HLA typing, urine tract evaluation, CMV serology for the recipient, kidney function, urinary sediment, look for albuminuria, glucose, oral glucose tolerance, lipid profile, checking for things like diabetes, hepatitis B, C, HIV. We did the compatibility, HLA typing and cross-match, LFTs, hemogram, renovascular angiography. Now, what's the problem with that? Cost. Cost of workup in my country is around 150 to 200,000 shillings. That's around $1,500, which obviously is unaffordable to most Kenyans, and I'm sure to most Africans as well. We have a national health insurance fund in my country, which assists with transplant, so pay a part of the cost of the transplant, but they don't pay for pre-transplant workup, and they don't pay for medications thereafter. So that's a challenge. Okay, in this particular patient of mine, we got funds through philanthropy. So we had institutions which are willing to support. So the hospital has a welfare program in which they thought that this child would benefit, and they put him through and actually funded him through till the end. But that doesn't happen with most patients, right? These are some of the pictures when you're looking at the harvesting and reperfusion of the kidney. So you see this is this site on this side where you're looking at reperfusion is the beautiful site when the kidney becomes pink, and that is a very beautiful sight to any nephrologist who goes to theater during a transplant. All right, during intra-op, we need to maintain blood pressures above 100, systolic, CVP above 10, always critical. In this particular child, reperfusion took place and we covered uneventfully. Doppler showed good flows and urine output was good. Now, very important, whenever we are doing transplants in our patients, good anesthetic workup. You need a fantastic anesthetist who's actually looking at those things, because acute tubular necrosis, acutely because of hypoperfusion, is not very uncommon. Come to immunosuppression, basilixumab was given to this child, tacrolimus. So we went the tacrolimus, MMF, mycophenolate mofetil, and prednisolone. Again, in our setup, resource poor, limited settings, choice of medication is based on evidence, but also determined by finance. This child was not curtailed by that, but if you think about it, tacrolimus in our country is more expensive than cyclosporine, and you might have to go cyclosporine vis-a-vis tacrolimus. MMF is more expensive than azathioprine, so you might have to go that route. When you look at the data in tacrolimus vis-a-vis cyclosporine, so graft survival rates are pretty similar with TAC and cyclosporine-based regimens in children. And you have, when you look at these studies which have looked at so many children, 986 children, they found that the graft survival rates was around 97 to 98%. Now, the only problem with cyclosporine, especially with girls, is the aesthetics, because you do tend to get gum hypertrophy and hirsutism, and a lot of people tend to prefer tacrolimus vis-a-vis cyclosporine. On the other hand, there is anecdotal data about tacrolimus increasing the incidence of diabetes, especially in the Black population. So you got to, whenever you're choosing the medication, besides the science behind, you need to think about these other things. When you look at MMF vis-a-vis azathioprine, so the long-term effect of MMF seems to be safe and beneficial. When you look at, this was seen in that study from Germany, where they look at 5-year outcomes in pediatric patients with MMF-based renal transplantation. And survival rates are pretty good with MMF. When you looked at the historical control of children who had received azathioprine with calcineurin inhibitor and prednisone, it seems to be much more superior. In terms of infection control, prophylaxis for PJP, for septrin, TB, isoniazid, local antifungals, and CMV prophylaxis in case we had any risk of CMV. So that's all initiated. So what's the ideal choice of immunosuppression for resource poor limited setting? We rely on data, and unfortunately most of the data comes from the West. And for that, we need to compile our own local data for the same, because what may work for different populations might not work for ours. But because we don't have our local data and we do not have our strong databases, we tend to use what we are given. And I think that might need to change. We may need to go for cheaper options or get good generics, so make our own drugs, which would reduce the cost for transplantations. Because unless we reduce the cost of transplantations, transplantation will continue to be out of reach for most of our populations. Concerns with monitoring, so we need to monitor the labs for tacrolimus or cyclosporine levels, and lab support is absolutely important. Until recently in my country, we used to have to send the labs outside the country to look to do tacrolimus and cyclosporine levels. Now we can do it back here because our capacity has improved and we are doing many more transplants. But we still need to reduce the costs of this monitoring. Whenever you do a transplant, you need a multidisciplinary action. You need a big team of nurses, surgeons, urologist, anesthetist, nutrition counselor, pediatric nephrologist. And no one person in this is more important than the other. Everyone has to work together as a team. It's a joint effort, and must say it doesn't pay too well. So this was post-transplant. This child, as you can see, with the donor, happy and happy to be off dialysis and happy to have been passing urine after a very long time. So he did very well, was discharged home to Bondo. Bondo is the lakeside town. Initially was reviewed every month, then 3 monthly after 1 year. The kidney function behaved very well and medications were available, and he stayed with the donor and they were doing quite well. Then 9 years down the line, so he was reviewed in September 2017. His BUN at that time was 7 millimoles, creatinine 125. CSA levels were the cyclosporine levels. So we had to change from TAC to cyclosporine because of availability at that time. And cyclosporine levels were doing well. He was taking meds well, had joined secondary school in Kisumu and was boarding. Again, later in 2018, I got a call from him saying he was not feeling well. So I told him we need to come back to Nairobi. When I saw him, he was sick looking, had lost 2 kilos of weight. Investigations, as you can see, BUN had gone up to 37, creatinine of 1,850 and cyclosporine levels of 10. So he initially told me he's been taking all his medicine. On further inquiry, he told me then that he had stopped taking his meds because he felt good. He did not think he was sick. And he was ashamed of taking the medicines in front of his friends. We did a renal biopsy, showed features of rejection, put on IV fluids, anti-rejection protocol with the transplant team. No improvement, had to restart on hemodialysis. He went back to Kisumu on twice weekly dialysis. He got a catheter infection whilst he was there. He returned to Nairobi. Hemodialysis continued whilst he was here. He had a sudden cardiac event and he passed away. That was around 10 years. So you can imagine that was what we felt like. So 9 to 10 years down the line, and this is what we got. The issues were compliance, availability of support systems, and follow-up outside the main transplant centers. When you look at adolescent renal transplant recipients, they enjoy the best 1-year survival rate of any age group, but they have the worst long-term outcome. Their non-adherence is the most common factors for graft rejection, and impact in this group is more than the rest of the transplant people. So non-adherence in this particular group is the worst that you can come across. As you can see in this graph, this was where he was, where your recipients with at least 1 year of graft function, and this is where you tend to see that it was the graft failure rate was the highest at this stage. So when you look at teenagers, and for some of us who are parents as well, it's a special breed. We need to try to establish autonomy from the guardians while still need help. So it's a contrast. You need autonomy, but they need help. They need guidance and support from the guardians and medical personnel. They don't have the ability to anticipate anything abstract for the long-term consequences. So what they see is very short-term effects. And because of that, there's frustrations for the adolescent and all the support system. The pediatric nephrologist, we don't know where they stand, whether they come to the pediatric nephrologist or they go to the adult nephrologist. They keep moving up and down, and it's frustrating for everybody. What are some of the solutions we could offer? So one is obviously observation in the hospital, which is accurate. So you can be giving them medications and they'll be taking it, but it is largely impractical. You can be doing the trough levels. It's very objective, but only provides recent information. Variability, these are when you look at the TAC levels or cyclosporine levels and you look at the standard deviation, higher the standard deviation, the higher the rejection rate. And you need multiple levels, again, increasing cost of follow-up. Indirect ways, if you look at there is electronic pill count, pharmacy records, self-reporting, collateral report. Someone else, that someone you trust, can be looking at them. This child was in a boarding school, so that kind of follow-up is very, very difficult. So repeated interventions, interventional sessions to provide anticipatory guidance, education, monitoring, motivational interviews, especially with people they like, so maybe singers, sports person, politicians who would actually help. We need to increase blood monitoring and graft function monitoring in that age group. So what we normally do 3 monthly after 1 year, I think once they reach adolescent, I think we should be doing much more. Multi-dose pill box, so all those things are possible interventions. Okay, but it's difficult. When you look at outcomes, so renal failure persisting after transplant, called delayed graft function, the graft survival rate 15 to 25% lower in those with delayed graft function. So children who initially get the function is poor because of ATN or some thrombosis or accelerated rejection, they tend to have the problem with rejection later on. So you need to actually have very close follow-up at that point in time. So close monitoring, make sure you're checking the urine levels, absolutely important. If you don't have a team that can be on the ground all the time, and that happens in our setups where you have small number of people who are actually doing specialized stuff and they have to move around, it becomes a problem. Other complications like hypertension, quite common, so they need to be followed and may have an association with graft failure later on. Things like infections, CMV seropositivity for CMV. In this particular patient, and donor was negative, so was no need for prophylaxis. You need to look for things like urine leaks, initially especially, and need to have a urologist on board. Chronic allograft nephropathy is the most common cause of graft loss among transplant recipients, including children. Risk factors for loss of allograft due to chronic rejection was recently evaluated. We looked at least one episode of acute rejection. Again, if you gave low doses of cyclosporine, it was associated with increased risk of chronic rejection, and that is why monitoring the levels was very, very important. This child had refused to take medication, so we had acute on chronic. So when you look at challenges that we have in resource limited settings and what we can do about it, We need to develop a coordinated transplant program for pediatrics, which would be multidisciplinary. They need to go for counseling so that they are ready for the transplant. We need to reduce the cost of workup and drugs for the patients. We also need to increase awareness. We need to have legislation that would allow for cadaveric transplants in Africa so that we have access to more kidneys for transplantation. And very, very important, I think I cannot overemphasize this, we need a database for African pediatric transplants to come up with our own protocols. Okay, what works for Africa? As I always say, African problems needs African solutions. This was the team that looked after the patient during the transplant, and everyone was happy at that time. We need to acknowledge the nephrologists, the surgical team, nurses, junior doctors, other colleagues. In my country, I know whenever we have transplants in my city, in Nairobi, all doctors, all pediatric nephrologists get together. And it's certainly a team. Would like today, you see Professor Abdallah here. He is the pioneer of pediatric nephrology, our father of pediatric nephrology in Kenya, and also in Africa is one of the first presidents of AFRAN. Professor Dr. A.J.O. Were, who was the sitting president of AFRAN when he passed away last year. And I remember Professor Abdallah, when we did this particular transplant and I was green, he is the one who was holding my hand and telling me everything is going to be okay. So besides everything, we need mentors and we need champions who can push for pediatric transplantation in Africa. This is Professor Laurent from Cote d'Ivoire, good friend of mine, pediatric nephrologist, prominent pediatric nephrologist, doing fantastic work in the French-speaking part of Africa. And she also passed away last year. We miss these guys, but we need to carry the legacy on. Thank you.
Thank you, Dr. Bashir, for that elaborate talk, which has showed us what are the challenges that are faced by patients, doctors, and caregivers, because this is not something that is faced by one person and one party only. So it has been interesting to see the journey of that patient that you showed us through. And maybe I should take this time now to welcome questions and participation, comments from the audience. I see Dr. Bima has his hand up already.
Oh, thanks,
Yes.
Francis. And Bashir, thanks a lot for that very illuminating presentation. You know, going through that case and looking at all the challenges that we faced was one of the best things that we've had so far. And I must tell you that it is not very different from the challenges that we are facing back home. In fact, on Tuesday, we did a transplant in a 16.5 kilogram child, doing very well at the moment, just that he doesn't want to drink. Okay, but just to make a comment first, and that is, you brought up this concept of teenagers and compliance. And I can tell you, it is one of the most challenging things in pediatrics, because if anyone can solve the problem of compliance, I'm sure they'll win the Nobel Prize. Okay, see, because it is extremely difficult. I've lost 2 transplants now in teenagers, not because of the fact there was something wrong with the transplant or for any other medical reason, but purely on the basis of compliance. So I am glad that you brought that up. So my question is, Bashir, given the fact that we don't have this kind of large transplant program with cadaveric donors, etc., what has been done in so far? Like, we've got an interest group working on promoting transplants, etc. Not that they are doing much better, but it does make a slight difference. So what are the reasons that you don't have cadaveric transplants in your region, etc.?
Yeah, thanks, Professor Mbima. I mean, you know, the truth of the matter is, I mean, first of all, yeah, comment on teenagers. I mean, none of us will be able to understand. I think when we were growing up, I think even our parents didn't understand us as teenagers. Yeah, it's a nightmare. I always fear for teenage transplant patients. Once they reach there, it's difficult time. Now, when it comes for cadaveric transplant, so you see, the problem with we don't have cadaveric transplant in our country is the legislation. We didn't have a definition of death, so we couldn't. So technically, death for us was when the heart stops beating. So
Right.
what we have worked on now is provide them with a definition of death where we can look at brain death and be able to harvest the kidneys. So the lobby is in place, things are in place, and we are all hopeful that we have a local program here, Kenya Renal Association, which has played a big role in trying to get the cadaveric transplants going. So we are very hopeful in the next few years we'll have the cadaveric transplant program going, and obviously we're going to need all the help we can from people like yourselves in South Africa. Again, even with when you're looking at transplant in terms of donors for living related, and this applies to children. I mean, even the parents, we have to convince them to give kidneys, because it's also cultural. So, giving part of your organs, it's not part of the culture. And it becomes very, very difficult when you're trying to convince a mother or a father to try to donate a kidney to the child. And, you can't buy or sell kidneys. So we have to convince these guys to actually be able to donate kidneys. I mean, look at this particular child. We had a neighbor who just donated the kidney without being asked for it, actually. We didn't even ask. She's the one who came up when we are talking about donation. And real parents, I've had, in fact, surprisingly, all the patients that we have had transplants with, the mothers, we would expect the mothers to donate. In my case, most of the mothers refused. It was the fathers who donated.
Oh, interesting.
So we need more education.
Yeah, I agree. So just one more comment, Francis, and then I'll be over. So we have interesting demographics in South Africa, like over close to 80% of our population are Black African, 10% is Caucasian, and the other small group are made of Asians and Chinese and whatever. So that's a population demographics. If you look at donation, it's exactly the direct opposite of that. Okay, where there's very few donations from our Black African patients, but the largest donations come from our Asian and Caucasian population. And you're absolutely right. It's largely a cultural issue. And unfortunately, it's something that you have to have a huge battle to get over. And it requires a lot of education. And it's also a generational thing, I think, to some extent. So yeah, thank you very much, Bashir, for that lovely talk. Thanks, Prof.
Thanks, Prof.
So, Dr. Bashir, Dr. Joseph, welcome.
I would like to thank Dr. Bashir for an excellent highlight on pediatric transplantation. But there are certain aspects of the children, I mean, as far as their size is concerned, and I imagine there must also be some legal aspects. If you talk about the size match, of course, the ideal size match would be the children of the same age, although the kidney, we know that it doesn't grow much larger. Could you please comment on that? Especially if you're talking about, probably that is why actually he's been highlighting to us, the youngest child was 5 years, and probably that brings actually even a limit on how small the transmissibility and size of as far as the transplantability of a child is concerned, depending on the size and also matching the recipient with the donor. And of course, this also goes with legal issues, especially we're talking about the age of consent. So I would like him to give a broad comment on those issues. Usually, of course, the donors are parents, And I suppose in a situation where you have cadaveric transplants, probably this is not an issue. You can get children who are donors anyway. So, but in our situation where we don't have established, cadaveric transplant programs where most of the donors we get are living related, I think it limits very much with children as far as those legal issues are concerned. I'm talking about size match and issues of consent vis-a-vis the age of consent. I would like him to comment on that. I suppose these are limitations actually that also limit the availability of the donors. Please, can you comment on that?
Yeah, thanks for those questions. So to answer the first one, who should donate the kidney to the child? It has to be an adult. A child, if it's a living donation program, you cannot have a child donating because, legally you can't until they can consent. So in my country, I know you can't donate your kidney unless you can't donate your organs until you reach the age of consent, which is 18 years in my country. So the question is does an adult kidney work in a child? The answer is yes. So they're depending on your center, how good your transplant surgeons are, you can do at different sizes of children. I know in many African countries, in South Africa, and I think even in Egypt, they are able to do transplants in children around from 15 kilos and above. So 15 kilos and above should be around 3-4 years of age. In my country, I think we can do more than 15 kilos. I have not done 15 kilos, but we have done the one for 5 years in Eldoret. And that one, I think, was around 17 kilos. So they were able to do it. The tricks are different. So instead of transplanting on the iliac vessels, then you do it on the aorta, descending aorta. So you can connect to that. It becomes easier. And because it's an abdominal kidney, you have space to actually put it in the abdomen. Again, I mean, you look at an adult kidney, it is around 10 to 12 centimeters. So it can be worked out, but it largely depends the size of the child to be transplanted. I'm sure in some places in the West where they're doing many transplants, they can be able to do transplants in smaller children. So it largely depends on your expertise and how good our transplant surgeons are. I hope I answered your question.
Yes, you have, man. Thanks very much. No, one more thing. Does the size of the vessels, I mean, to anastomose them, in children, I suppose, they are slightly smaller than, what to expect of adults. Does the size of these vessels and the process of anastomosis, does it contribute to the outcome of the operation?
It obviously it definitely can if you have very small vessels. That's why you need to do as part of the pre-transplant workup, you have to do a renal vascular angiography to be able to see how your vessels are. And that is why we tend to use the descending aorta for anastomosis as opposed to using the iliac vessels, because iliac vessels sometimes are very small in children. So it does. The incidence of things like thrombosis increases if your vessels are small. So yes, you are right, but we need to work them up prior to doing the transplant.
Yes, thank you, Dr. Joseph and Dr. Bashir. And so basically that's one of the reasons that we have to give aspirin to children after transplantation most of the time, which is not something that other transplant people do give, which is something that is limited to pediatric nephrologists might consider giving aspirin for these children, particularly in the first 3 months post-transplantation. So before we go to Dr. Lloyd, there's a question in the chat box. Somebody is asking, why is it that hypertension is more common for post-transplant from cadaveric transplant as opposed to, I think, living donation?
So
Yes, Dr. Bashir.
yes. Yeah, so I've seen that question, and I'm not really sure about that. But if I were to be pushed to give an explanation, I would think maybe because the cold ischemic time is slightly longer when you talk about patients with cadaveric transplants, probably the reason why your complications when it comes to the new kidney related complications would be higher. We also don't know most of the times what the what the status of those kidneys which have been taken for cadaveric transplants, what the status of the kidneys are. Most of the times, you don't test them like we do for healthy donors. So it is possible that there are insults that have led to the death of the patient whose kidney you are taking could be contributing to these other complications that are associated with the kidney of that patient. But I'm happy to listen to anyone else.
Thank you, Dr. Bashir. So may I welcome Dr. Lloyd, please?
Thank you, Dr. Bashir. That was a wonderful session, and actually you pointed out all the problems that you can get in a pediatric transplant. It's a very big, challenge doing a pediatric transplant. Right? It's years ago that I was associated with pediatric transplants in India, because at that point in time we did not have the luxury of pediatric nephrologists. So the thing is, and we always had a problem with the cyclosporine levels at that point in time, and I think children metabolize, CNI. Much more than adults, and so the levels are, I think, much higher. So, what levels do you use here in the African population? What would be your target levels? Immediate post-transplant and maintenance in CNI.
So initially we tend to use around 200, and then goes down to once you reach the chronic stage, we go down to around above 100. So if you can maintain around 100 on chronic dialysis, on chronic transplant, generally you're okay. But initially you need levels of between 150 and 200.
And when do you lower that from 200 to 100?
So usually from you slowly go down from around 3 to 6 months, then you start going down.
Okay. Yeah. Thanks. And you'll use your Tacrolimus in children now?
Yeah, we do Tacrolimus, and we use levels of 5 to 10. Usually, initially nearer 10, then nearer 5.
5. Okay. Thank you. Yeah. Thank you. So then that means they're not very different from adults also. 5 to 7 we use. They're not very different from adults. Okay.
Yeah. No, not different. The only problem is usually sometimes when you use the BD dosing like we do with adults, sometimes you do not achieve the trough levels that is required. And sometimes, as you might see, sometimes the smaller the child, you might need to do TDS dosing. For CNIs to be able to maintain those levels, because as you rightly mentioned, they tend to metabolize a bit quickly.
Thank you very much.
Thank you, Dr. Lloyd. There's another question in the chat box. Somebody is asking, first of all, what is is there any age limit for transplantation in children? And the other one is, who's the donor for a child? Is it a child or an adult? I think this one has been answered, but you might want to repeat it, Bashir.
Yeah. So yeah, age limit for transplantation. So there's no age limit, but it is limited by size and capability of your center. So it depends on what your transplant surgeons are comfortable with. Some people transplant after 15 kilos, some people transplant after 10 kilos. It's very difficult to transplant rather than anything else. So it's not specific age, but you need to feed the child to make sure that they reach to a certain size and they need to grow. And the donor has to be an adult. A child, because the child cannot consent, they cannot donate a kidney. At least I'm sure that's across the board. Okay.
Thank you, Dr. Bashir. There's another question in the chat box. What is the best, HT or PD for kids?
Yeah. So I mean, a bit out of the scope of this talk, but I'll answer it. What's best is what is best for you. If you are good at HD, then do HD. If you are good at PD, then do PD. No best answers. You do what you are good at.
Yes, just to add something on that, it is usually, I mean, hemodialysis can be done in children. There are centers that are doing hemodialysis for neonates, but then the challenge is getting the accesses, and in particular in limited, in our setting. So PD might be quite friendly when it comes to renal replacement therapy, particularly for the very, very young children. And most of the people will be very comfortable going with PD. But nonetheless, HD is possible. Yes, Dr. Lloyd, is your hand still up? Yes, do we have another comment from the audience? Maybe I should take this opportunity to thank everyone for participating in this talk, and thank you, Dr. Bashir, for sharing with us this interesting talk, as well as your experience in dealing with pediatric transplantation. We are also we have adult transplantation in Tanzania, and now we're struggling to introduce pediatric transplantation, and we've been able to do transplantation. The youngest is 9 years that we've been able to do transplantation locally, so we are also getting there. When we are being faced with the same challenges that you've alluded to. So maybe I should ask Dr. Lloyd to give the concluding remark. And on the same note, next week I might be in Nairobi, so I'll try to hook up with you, Dr. Bashir. I would wish to have a look at your dialysis unit and see you.
Yeah. I would love to have you on, man.
Thank you.
Make sure we get in touch.
Okay,
Excellent.
Dr. Bashir. Yes, Dr. Lloyd.
Yeah, excellent. So, Dr. Bashir, that was wonderful, and extremely grateful for having come out and given us your valuable time. And I can see you are across the hospitals in Nairobi, and this is a very valuable time for you. And it was a wonderful session, and actually touching a lot of local reality, and that is very, very important. The challenge is, you see, when you come to big centers, you go out to big centers, we train in big centers, but when we come back home, the difficulties we face are completely different. And I think, thank you for outlining that. And, you know, it's a challenge, and I'm sure in the years to come, we will have very good transplant programs in East Africa. Thank you so much for this wonderful session. Thank you very much.
Thank you for inviting me, and yeah, thank you for an interesting session, guys.
Yeah, thank you so much.